My name is Deontis Keys. I am a faculty member with the Housing Affinity Group, and my profession is I'm the Senior Manager of Communications and Community Mobilization at the AIDS Foundation of Chicago. I joined the collaborative because it was a community of practice that prioritized the person outside of what we come to know as patients of care, but then also prioritized us as partners in the process, partners in the solutions, but especially partners that we can count on, that we can trust, and people and partners in the process of bringing about innovation.
Hi, my name is Dottie Rains Dowdell, and I am a content expert faculty member for Create Equity Collaborative. I am a part of the Age Affinity Work Group. So, the reason that I joined the collaborative is because I wanted to lend my perspective as a woman living with HIV for about 30 years. I also have done some great work in the community, and I just wanted to have a place where I could share that to basically impact the HIV community.
My name is David Moody. I'm part of the Substance Users Affinity Group, and I joined this portion of the collaborative because I have some lived experience on both the treatment side and the customer side. So I joined as a faculty member and a content expert.
You know, racial inequity impacts HIV health outcomes in so many ways. When I think about folks who may be a little reluctant to, one, find out about their status because of maybe the mistrust of the healthcare system based off of maybe some historical experiences or even their own present experiences. I also think about even when we look at some of the research that talks about like who's engaged in care, who's not, who's virally suppressed, we see a lot of the racial inequities play out in those spaces as well. So we see that racial inequity can impact uh, a person being tested to engaging in care and treatment.
Where a person lives, their zip code, what they have access to, healthcare, pharmacies, grocery stores, food, nutrition, daycares, determines a person's life expectancy. And many of those zip codes are determined by a person's decision to see value amongst a community. So when thinking about racial inequalities, it impacts our outcomes because it's the outcomes of people's decisions and seeing value in a person's skin color or a person's race.
People who are my customers have an extreme distrust of the medical system. And it may not even necessarily be the medical system's fault, but it's the fault of just an endemic racism that happens throughout society. So people are used to being treated a certain way, so we expect to be treated a certain way. And because of that, we react as if we're already being treated that way. Microaggressions like little looks that we'll give people or a change in tone from this customer to this customer, because if you're talking to a customer over here and then your tone changes, like even imperceptibly to you, like that's why you have to like monitor yourself all the time. Not monitor yourself like punitively, but just be aware of the way that we're approaching situations. Expect the best and prepare for the worst. Unfortunately, what a lot of people are doing is expecting the worst and preparing for the worst. So if that's all we're preparing for, then we're never going to expect something better.
So my experience of making sure that my communities, the marginalized communities that I come from, had the information that is most accessible and valuable and applicable to them is one racial fight that I fight every day. And I experience it every day, and it eats me up. Racism and structural inequalities in the systems and in the institutions that we occupy and that serve us, uh, it's at the center of what we need to solve.
I remember testing HIV positive, and I was about maybe 16, and about a year and a half later, I remember I showed up in the emergency room because I had an allergic reaction. And as a part of the testing and the process, they make sure, you know, they do a series of tests. And one of the tests included a pregnancy test. And when the pregnancy test came back, it came back that I was pregnant. And I remember the nurse saying, if you want to terminate your pregnancy, we can set you up as early as next week. Not asking, if this is, did I want to keep the baby? Didn't have that type of conversation. And now that I reflect on that experience, I wonder if that was based on my race. Was it based off of gender? At the time I was on Medicaid, so was it based on my socioeconomic status? If I was white, would she have given me the same feedback? So I often wonder. And so that's why when I think about like racial inequity, I know it impacts health outcomes. I do. Because of how our identities intersect, you don't know if it's because of race, because of gender, because of class. There's so many things to consider. And I know it does play out because you begin to ask yourself like the why.
I wasn't aware of the facts and the figures of the District of Columbia, which is where I live. Those facts and figures are that like 1 in every 3 black males, gay black males, will contract HIV in their lifetime. At the time that I went to the clinic to get my diagnosis, I was unaware of that number. But the person who gave me my diagnosis, I think, knew all these numbers. And I think that he thought that I was being stupid or like myopic about my diagnosis. If he had considered that and like spoken to me as a human being, he could have softened that blow. Like he could have let me know ahead of time, here's the numbers, here's the facts, here's the figures, here's the possibilities. And then like maybe give me a moment of, are you ready for this? But because he saw me as somebody who he already knew the answer, he already knew the result because of because of whatever statistics applied to me, it wasn't important to him. Like I wasn't important to him. He felt like, well, you got in the car and you aimed it at the wall, so what do you expect? But I didn't know that I got in a car and aimed it at a wall. I thought I was just driving down the street, and then all of a sudden, there was no street anymore. The clinic where I've been receiving my care for the past decade or so, the first time I walked in there, I was greeted by, first of all, I was greeted by a transgender individual who was so like just welcoming. Like she made me feel like I'd already been there before. And like I was with I forget who I was with, but it was like, do they think I'm somebody else? Because like it seems like maybe they have me mixed with somebody. And the person I was with who had brought me there was like, no, it's just how they are. And because there's a representation of me in you, then I'm going to treat you like I would treat myself. Like make sthat we're always feeling welcome.
What they should start doing is listening. And then how they can do that is by, developing products and practices that help prioritize, people's feedback that also supports the actual practice of improvements, the trial and testing of that.
If we have biases, that first we recognize them. Because if we don't recognize that we have these biases, then we're going to work in conjunction with them without even realizing that they're there. Watch yourself. You can monitor yourself and see, okay, so this is how I interact with this person. Why did I interact differently with this person this way? So I had a favorable outcome with this person over here. So let me go ahead and apply what I did over here as if this other customer is the customer where everything worked out well. What we can do is we can make sure that we're stepping outside of those biases, get those out of the way, and stop filtering everything through our expectations, and take each person as an individual, which allows us the opportunity to then, and it takes time, and over time, people will begin to see that they're being given the opportunity to present themselves, not as the bias that you see.
Like really drilling down to be racially specific. And I know the research is out there, but I think us continuing on in that vein will help make a difference. And not just to uncover what we like already know, but now developing that once now what strategies can we develop to begin to work on bringing about change? When I think about the housing, the substance abuse, the mental health, the age, if we begin to drill down the data, in relation to race, what will we find? Will we still see the disparity? And then the next question is why? What's happening? Why is it happening? And what do we need to do to improve?
And the most important thing that the customers can receive is just grace and understanding and compassion. And compassion is not sympathy. Let's make clear, because it's not sympathy and it's not pity. It's just grace. Like just allowing people to be themselves without judging them for it.
Prioritize the involvement of the person greater than what we are commonly involved in as patients of care, but more so as partners in the process, partners that we can hold accountable and trust, but then also partners in the innovation.
When we went to the back to see a nurse who was also the benefits counselor, he was wearing short sleeves, and she noticed his track marks. And instead of commenting on, his drug use per se, she commented on, "Oh, that doesn't look great. Does that hurt?" And then she pulled out some needles and pulled up a video and diagrams and showed him how to inject safely. Didn't pass any judgment on that you shouldn't be doing this, but just made sure went straight to harm reduction. So it was an acceptance that was important and immediately latched him onto that clinic. He was determined that he was going to go there and nowhere else for the rest of his life, because he could tell that they weren't in judgment of him, but they cared about it.
Yes.
Collaborative.
I love it.
We